Welcome back to Pediatric Case Review. Today, we tackle one of the most important rare metabolic disorders a general pediatrician can encounter in the newborn period, Zellweger Syndrome. This is the most severe peroxisome biogenesis disorder, and recognizing it early can change the entire course of family counseling. Have you ever met a profoundly floppy newborn and wondered whether the cause was the brain, the muscle, or something deeper at the cellular level? In this case-based review, we will work through 14 clinical cases covering presentation, biochemistry, investigations, treatment, and genetic counseling. Let's get into it. Let's begin with our first case. A 3-day-old male is referred for profound hypotonia and poor feeding. His birth weight was 3.1 kilograms after an uncomplicated delivery. On examination, he is a floppy infant with a weak cry, a large anterior fontanelle, widely open sutures, a high forehead, hepatomegaly 3 centimeters below the costal margin, and nystagmus. An electroencephalogram shows multifocal epileptiform discharges. The question is, which additional feature most strongly suggests Zellweger syndrome over other causes of neonatal hypotonia? Option A, macroglossia and umbilical hernia. Option B, rocker bottom feet and clenched fists. Option C, sensory neural hearing loss, renal cortical cysts, and craniofacial dysmorphism. Option D, low birth weight and temperature instability. The correct answer is C, sensory neural hearing loss, renal cortical cysts, and craniofacial dysmorphism. The key to Zellweger syndrome is the pattern of multi-organ involvement. Sensory neural hearing loss is present in more than 90% of cases. Renal cortical cysts are highly characteristic and can be detected on ultrasound. The craniofacial triad includes a high forehead, a flat nasal bridge, and epicanthal folds. This combination of brain, liver, kidney, eye, and ear involvement is what distinguishes Zellweger from a pure motor disorder. Option A points toward Beckwith-Wiedemann syndrome, while option B suggests trisomy 18, also known as Edwards syndrome. Now to our second case. A 1-week-old female is admitted to the neonatal intensive care unit. Her parents have noticed an unusual facial appearance since birth. Examination reveals a high forehead with large, widely spaced fontanelles, hypoplastic supraorbital ridges, a broad, flat nasal bridge with epicanthal folds, severe hypotonia, and hepatomegaly on palpation. The question is, which metabolic condition most likely explains this presentation? Option A, Zellweger syndrome, a peroxisome biogenesis disorder. Option B, neonatal lupus erythematosus. Option C, congenital rubella syndrome. Option D, glycogen storage disease type 2, also known as Pompe disease. The correct answer is A, Zellweger syndrome, a peroxisome biogenesis disorder. The classic craniofacial triad is the major clue here: a high forehead with large fontanelles and open sutures, a broad, flat nasal bridge with hypoplastic supraorbital ridges and epicanthal folds, and the combination of hepatomegaly with profound hypotonia. Neonatal lupus typically presents with a rash or heart block, not this dysmorphism. Pompe disease features cardiomegaly rather than craniofacial changes. The single most important next step is clear. Whenever you see this triad of dysmorphism, hepatomegaly, and hypotonia, order plasma very long-chain fatty acids immediately. Our third case. A 2-week-old male presents with profound hypotonia and minimal spontaneous movement. He has a high forehead, bilateral cataracts, nystagmus, hepatosplenomegaly, and requires nasogastric tube feeds. A peroxisomal disorder is suspected, and a skeletal X-ray is performed. The question is, which finding would further support a peroxisomal disorder? Option A, cortical thickening of the long bones. Option B, osteopetrosis with a bone-in-bone appearance. Option C, periosteal reactions suggesting metaphyseal fractures. Option D, chondrodysplasia punctata, which means stippled epiphyses. The correct answer is D, chondrodysplasia punctata, the stippled epiphyses. These are punctate calcifications within cartilage caused by impaired plasmalogen synthesis in peroxisomes. They are typically found at the knees, the hips, and the spine on skeletal X-ray. This finding is also seen in rhizomelic chondrodysplasia punctata, another peroxisomal disorder, which is why it supports the diagnosis. For contrast, cortical thickening would suggest healing fractures. A bone-in-bone appearance points to osteopetrosis, and a periosteal reaction suggests trauma or infection. Stippled epiphyses are a valuable and specific radiographic clue. Our fourth case. A metabolic consultant is explaining to a pediatric resident why a neonate with Zellweger syndrome has markedly elevated very long-chain fatty acids in the plasma. The question is, which statement best explains the primary biochemical defect? Option A, deficient peroxisomal beta oxidation of very long-chain fatty acids due to absent functional peroxisomes caused by biallelic PEX-G mutations. Option B, deficient lysosomal acid lipase leading to cholesterol ester accumulation. Option C, absent mitochondrial beta oxidation causing medium-chain fatty acid accumulation. Option D, defective fatty acid transport across the inner mitochondrial membrane. The correct answer is A, deficient peroxisomal beta oxidation of very long-chain fatty acids due to absent functional peroxisomes caused by biallelic PEX-G mutations. The PEX-G mutations produce defective peroxin proteins, which causes failure of peroxisome biogenesis. This matters enormously because peroxisomes are the only site in the cell capable of beta oxidation of very long-chain fatty acids, longer than 22 carbons. As a result, carbon-26 fatty acids accumulate, and the elevated carbon-26 to carbon-22 ratio becomes the biochemical hallmark of the disorder. PEX1 and PEX6 together account for roughly 65% of all cases. Our fifth case. This is a case conference on a confirmed Zellweger neonate. The metabolic specialist notes that plasmalogen levels are markedly reduced in the red blood cells. The question is, why does this matter clinically? Option A, plasmalogens are needed for glucose transport across the blood-brain barrier. Option B, reduced plasmalogens lead to impaired pancreatic enzyme synthesis. Option C, plasmalogens are essential components of myelin sheaths and cell membranes, and their deficiency causes demyelination and neuronal damage. Option D, plasmalogens are required for calcium absorption in the small intestine. The correct answer is C. Plasmalogens are essential components of myelin sheaths and cell membranes, and their deficiency causes demyelination and neuronal damage. Plasmalogens are specialized phospholipids synthesized exclusively in peroxisomes. They constitute roughly 30% of the phospholipids in brain white matter, making them critical for myelin integrity. When peroxisomes fail, plasmalogen deficiency leads to defective myelination, producing the leukodystrophy that is visible on magnetic resonance imaging. Conveniently, plasmalogen levels can be measured through a red blood cell assay, which provides a simple and accessible screening test. Our sixth case. A 10-day-old male presents with profound neonatal hypotonia and seizures. Examination reveals facial dysmorphism, including a high forehead and epicanthal folds, along with hepatomegaly. Renal ultrasound shows cortical cysts. Zellweger syndrome is high on the differential. The question is, what is the most appropriate first biochemical test to order? Option A, urine organic acids. Option B, serum quantitative amino acids. Option C, serum copper and ceruloplasmin. Option D, plasma very long-chain fatty acids, including the carbon-26 level and the carbon-26 to carbon-22 and carbon-24 to carbon-22 ratios. The correct answer is D, plasma very long-chain fatty acids. An elevated carbon-26 level and an elevated carbon-26 to carbon-22 ratio are the primary biochemical hallmark of Zellweger syndrome. This test has a sensitivity above 98% and is available at most metabolic laboratories. Urine organic acids would identify organic acidemias, and serum amino acids would identify amino acidopathies, but neither detects this disorder. The follow-up workup includes phytanic acid, red blood cell plasmalogens, and then PEX gene sequencing. The key teaching point is simple. Order plasma very long-chain fatty acids first, and do not wait. Our seventh case. A brain magnetic resonance imaging is performed on a 3-week-old infant with suspected Zellweger spectrum disorder, and the neuroradiologist calls to discuss the findings. The question is, which brain magnetic resonance imaging finding is most characteristic of Zellweger syndrome? Option A, periventricular leukomalacia with cystic changes. Option B, Dandy-Walker malformation with posterior fossa cysts. Option C, bilateral subdural hematomas with midline shift. Option D, polymicrogyria with leukodystrophy and germinal-lytic cysts. The correct answer is D, polymicrogyria with leukodystrophy and germinal-lytic cysts. Polymicrogyria, often in a perisylvian distribution, reflects a cortical migration defect because peroxisomes are essential for normal neuronal migration. Leukodystrophy represents defective myelination from plasmalogen deficiency, so the white matter appears hypomyelinated. Germinal-lytic cysts arise at the germinal matrix and are characteristic, though nonspecific. For contrast, periventricular leukomalacia is related to prematurity and is not a feature of this disorder. These magnetic resonance imaging findings are irreversible, which makes them critical for prognosis and for family counseling. Our 8th case. A 2-week-old female has elevated plasma carbon-26 and an elevated carbon-26 to carbon-22 ratio, reduced red blood cell plasmalogens, elevated phytanic acid, and a brain magnetic resonance imaging showing polymicrogyria and leukodystrophy. A clinical diagnosis of Zellweger syndrome has been established. The question is, what is the gold standard for definitive diagnosis and genetic counseling? Option A, electron microscopy of a liver biopsy showing absence of peroxisomes. Option B, skin fibroblast culture with peroxisome function studies only. Option C, identification of biallelic pathogenic PEX gene mutations through a next-generation sequencing panel or whole exome sequencing. Option D, elevated pipocholic acid in the cerebrospinal fluid. The correct answer is C, identification of biallelic pathogenic PEX gene mutations through a next-generation sequencing panel or whole exome sequencing. Molecular genetic testing is the current gold standard because it identifies the biallelic pathogenic variants in the PEX genes that cause the disorder. This is essential for accurate genetic counseling and for prenatal diagnosis in future pregnancies. There are more than 13 PEX genes known, and PEX1 alone accounts for more than 60% of cases. Electron microscopy was used historically, but has now been replaced by molecular testing. Elevated pipocholic acid is supportive, but nonspecific. Our 9th case. A couple whose first child died from classic Zellweger syndrome at 8 months attends the genetics clinic while expecting another child. The geneticist explains that Zellweger spectrum disorder is actually a clinical continuum. The question is, arranged from most severe to mildest, which option correctly lists the Zellweger spectrum disorders? Option A, infantile refsum, then neonatal adrenoleukodystrophy, then Zellweger, then Heimler. Option B, neonatal adrenoleukodystrophy, then Zellweger, then infantile refsum, then Heimler. Option C, Heimler, then infantile refsum, then neonatal adrenoleukodystrophy, then Zellweger. Option B, Zellweger, then neonatal adrenoleukodystrophy, then infantile refsum, then Heimler. The correct answer is D, Zellweger syndrome, then neonatal adrenoleukodystrophy, then infantile refsum disease, then Heimler syndrome. All 4 conditions are caused by biallelic PEX gene mutations. Zellweger syndrome is the most severe, with neonatal onset and death typically before 1 year of age. Neonatal adrenoleukodystrophy is slightly milder, with survival measured in months to years. Infantile refsum disease has a childhood onset, with retinopathy and hearing loss. Heimler syndrome is the mildest, featuring only hearing loss and dental enamel defects. Importantly, the same PEX gene can cause different severity depending on how much residual peroxisome function remains. Our 10th case. A 5-day-old female presents with severe neonatal hypotonia, and we are building the differential diagnosis. The question is, which features most differentiate Zellweger syndrome from spinal muscular atrophy type 1? Option A, the severity of the hypotonia. Option B, hepatomegaly plus craniofacial dysmorphism plus renal cysts plus elevated plasma very long-chain fatty acids. Option C, the presence of neonatal seizures. Option D, a family history of consanguinity. The correct answer is B, hepatomegaly plus craniofacial dysmorphism plus renal cysts plus elevated plasma very long-chain fatty acids. Spinal muscular atrophy type 1 is a pure motor neuron disease. It has no dysmorphism, no organomegaly, and normal biochemistry. Zellweger syndrome, by contrast, is multisystemic, involving the liver, kidneys, brain, eyes, and ears all together. The key differentiator is the elevated plasma very long-chain fatty acids, which are always normal in spinal muscular atrophy. Because both conditions share profound hypotonia, this clinical overlap demands a biochemical workup. Spinal muscular atrophy type 1 is confirmed by the SMN1 deletion, while Zellweger is confirmed by PEX gene mutations. Our 11th case. A 3-week-old male has confirmed Zellweger syndrome with biallelic PEX1 mutations, presenting with profound hypotonia, neonatal seizures, and hepatomegaly. His parents ask whether there is a treatment that can cure their child. The question is, what is the most accurate statement about treatment? Option A, gene therapy targeting PEX1 is approved and curative if started in the neonatal period. Option B, bone marrow transplantation is the treatment of choice and can reverse neurological damage. Option C, no curative therapy exists and management is supportive, including seizure control, nutrition, vitamins, and multidisciplinary care. Option D, Lorenzo's oil has been proven to halt neurological progression in Zellweger syndrome. The correct answer is C, no curative therapy exists and management is supportive. There is currently no gene therapy or transplant available for this disorder. Care focuses on managing symptoms. Anti-epileptic drugs such as phenobarbital and levetiracetam are used for seizure control. Nasogastric tube or gastrostomy feeding supports nutrition. Fat-soluble vitamins A, D, E, and K are essential because of cholestasis. Hydrocortisone treats adrenal insufficiency. Hearing aids or cochlear implants address sensorineural hearing loss, and ophthalmology follow-up manages cataracts. Lorenzo's oil is used in X-linked adrenoleukodystrophy, but is not proven here. A multidisciplinary team and a palliative care discussion are essential. Our 12th case. A 6-month-old infant with a Zellweger spectrum disorder, the neonatal adrenoleukodystrophy variant, presents with poor weight gain, skin hyperpigmentation, a serum sodium of 128, and a serum potassium of 6.2. A cortisol stimulation test confirms adrenocortical insufficiency. The question is, which treatment is indicated? Option A, hydrocortisone replacement therapy with fludrocortisone if mineralocorticoid deficiency is confirmed. Option B, monthly adrenocorticotropic hormone stimulation to restore adrenal function. Option C, high-dose vitamin C supplementation to support cortisol synthesis. Option D, licorice root extract as a natural mineralocorticoid. The correct answer is A, hydrocortisone replacement therapy with fludrocortisone added if mineralocorticoid deficiency is confirmed. In this disorder, very long-chain fatty acid accumulation causes adrenocortical lipid toxicity and impaired peroxisomal steroid synthesis. Physiologic hydrocortisone replacement is given at 8 to 10 milligrams per square meter per day in divided doses. During illness or surgery, the dose is tripled, which is called stress dosing. Fludrocortisone at 50 to 100 micrograms per day is added when mineralocorticoid deficiency is confirmed. The skin hyperpigmentation reflects elevated adrenocorticotropic hormone. An adrenal crisis is fatal if untreated, so therapy must not be delayed. Our 13th case. A 2-week-old male with classic Zellweger syndrome presents with profound hypotonia, uncontrolled neonatal seizures, hepatomegaly, and a brain magnetic resonance imaging showing polymicrogyria and severe hypomyelination. His parents ask about their child's expected prognosis. The question is, what is the most accurate prognostic statement? Option A, with aggressive treatment, most children achieve near normal neurodevelopment by age 3. Option B, most infants with classic Zellweger syndrome do not survive beyond the first year of life due to respiratory failure, seizures, or recurrent infections. Option C, the condition stabilizes after 6 months, and children typically survive to the teenage years. Option D, liver transplantation corrects the neurological complications and improves survival. The correct answer is B. Most infants with classic Zellweger syndrome do not survive beyond the first year of life. Classic Zellweger syndrome carries the worst prognosis of all the Zellweger spectrum disorders, with death typically occurring between 6 and 12 months of age. The common causes of death are respiratory failure, aspiration pneumonia, intractable seizures, and recurrent infections. The brain malformations, including polymicrogyria and leukodystrophy, are irreversible, and no treatment reverses them. For this reason, palliative care and goals of care discussions are essential from the time of diagnosis. The recurrence risk is 25% per pregnancy, so genetic counseling is mandatory. Our 14th and final case. After the death of their first child from Zellweger syndrome at age 9 months, a couple seeks genetic counseling. Both parents are confirmed PEX1 carriers, each heterozygous for the same variant. They are now planning a second pregnancy. The question is, what is the most important counseling point for this couple? Option A, recurrence risk is negligible because de novo mutations cause most cases. Option B, only maternal age affects recurrence, and trisomy screening is sufficient. Option C, recurrence risk is 50% in an autosomal dominant pattern, and amniocentesis confirms it. Option D, recurrence risk is 25% per pregnancy in an autosomal resistive pattern, and prenatal diagnosis is available through chorionic villus sampling or amniocentesis with PEX1 testing. The correct answer is D. The recurrence risk is 25% per pregnancy, following an autosomal recessive pattern with prenatal diagnosis available. Because both parents are obligate PEX1 carriers, each pregnancy carries a 25% chance of an affected child, a 50% chance of a carrier, and a 25% chance of an unaffected child. These probabilities are independent of prior outcomes. Prenatal diagnosis can be done by chorionic villus sampling at 10 to 12 weeks or amniocentesis at 15 to 18 weeks with PEX1 molecular testing. Pre-implantation genetic testing through in vitro fertilization is the most reliable option. Genetic counseling should happen before the next pregnancy, not after. Before we close, I want to tell you about our community. Pediatric Case Review is a learning community built for clinicians and students like you. All of our videos are organized by body system, so you can move through cardiology, neurology, nephrology, and more in a structured and efficient way, with everything in one place. Every presentation used in our videos is also available as downloadable images, so you can review and practice all of the questions offline at your own pace. If you would like details on how to join, simply comment below on this post, and we will message you directly. Let's bring it all together with the key takeaways. First, biallelic PEX gene mutations lead to absent peroxisomes and very long-chain fatty acid accumulation, the core biochemical cascade. Second, the classic clinical triad is neonatal hypotonia, craniofacial dysmorphism, and hepatomegaly, alongside seizures and renal cortical cysts. Third, the first test is plasma very long-chain fatty acids with sensitivity above 98%, confirmed by a PEX molecular gene panel. Fourth, the brain magnetic resonance imaging hallmarks are polymicrogyria, leukodystrophy, and germinal-lytic cysts. Fifth, care is supportive only, as no cure exists. And sixth, the recurrence risk is 25%, so genetic counseling is mandatory. Thank you for joining this case-based review of Zellweger Syndrome. I hope these 14 cases have sharpened your approach to the floppy, dysmorphic newborn and reminded you to reach for plasma very long-chain fatty acids early. Remember that this content is educational and does not replace current clinical guidelines or specialist expertise for individual patient management. If you found this review helpful, please follow the channel for more case-based pediatric presentations covering both rare and common conditions. If you have any questions or there is a topic you would like us to cover next, leave a comment below. We read every comment, and we look forward to seeing you in the next review.